We'll get started in 1 second here. Feel free to put your name and organization in the chat. We'd love to know who's on the call. So I'm going to read some wiretap information. In accordance with the wiretap, it's against the law in Pennsylvania to record oral conversations without the permission of the folks involved in most circumstances. So this session is being recorded for training and/or record-keeping purposes, and by participating in this session, you are consenting to the recording, retention, and use of this session. At any time, if you have a question or comment, please feel free to place that in the chat, and we will respond to you as soon as possible. If you'd like to ask your question or comment verbally, please note that by doing so, you are consenting to the recording, retention, and use of your statements recorded as part of this session. So please exit the call if you don't want to be recorded, and you'll be able to review the video in its entirety on the DDAP webpage at a later time. We also have an AI program notice. The use of any artificial intelligence, AI software, or features that record, transcribe, or analyze this webinar is strictly prohibited. If your device has an AI program or function enabled, please disable it now. Participants found to be using AI tools during the session may need to be removed from the webinar. So we'll go ahead and get started. Before we begin, a reminder that the alignment with the ASAM criteria 2013 edition is required of drug and alcohol treatment providers. If you have any questions regarding the ASAM criteria specifically, you can feel free to email the ASAM resource account. That address is shown on the screen. Learning objectives for today's presentation are on the screen. You want to take a look at those? Before we start with the presentation, Amanda Madison will ask our poll questions for today.
Morning, everyone. So first, if you could tell us your role, please. If you cannot see the poll on your screen, you can put your role in the chat. So are you an executive director, clinical supervisor, counselor, administration, medical staff, support staff, case manager from DDAP, an SCA, or an MCO? Looks like we got about 80 some responses. Thank you. Our next poll question asks, what barriers do you face when individualizing treatment? Staff training, staff comfort level, individual resistance or engagement concerns, program policies, lack of resources, or time constraints, or any other issues that you feel are a barrier to you individualizing treatment? Put that in the chat. Looks like we're pretty split between staff training, lack of resources, and time constraints. We have 37% saying individual resistance or engagement concerns. Thank you all.
Yeah, thank you everybody for participating in that. So we'll move on with today's presentation. Today's presenter today is Amy Maurizio from St. Luke's Penn Foundation. Amy has over 25 years of experience working with individuals with substance use disorders. She currently serves as Director of Operations for Substance Use Disorders and Recovery Services at St. Luke's Penn Foundation. Amy earned a bachelor's degree in psychology from Misericordia University, a master's degree in public health education from Arcadia University, and an MBA from Strayer University. She is a certified advanced alcohol and drug counselor and a certified clinical supervisor. Amy's professional interests include co-occurring disorders, program development, quality improvement, and leadership. And today, Amy will share her organization's approach to behavioral interventions. Please keep in mind this is one provider's perspective. and is meant to spark discussion and reflection, not to prescribe a one-size-fits-all solution. After today's presentation, we'll read a case discussion, and Amy will walk us through from her organization's perspective, and then we'll invite participation from participants. We encourage everyone to keep an open mind, whether or not you agree with everything presented, and to share your own experiences, including any successes you've had using different approaches. The goal is to learn from each other and hear a range of strategies and foster a collaborative and respectful dialogue. So with that, welcome, Amy. The floor is yours.
Thank you, Gloria. Thank you for having me today, and I'm happy to share how our program handles some of the approaches to some of the challenges that I think we all tend to see when providing treatment for substance use disorders. So the scope of this presentation is to share our approach, and I want to caution you that what you hear today is not groundbreaking or cutting edge, but just a structured approach that is designed to foster consistency among counselors and other members of the treatment team in how we respond to situations such as positive drug screens or attendance in treatment, as well as other challenges that we may run into. And while also encouraging client accountability in terms of how they meet their treatment plan goals, given some of the challenges that are presented. And although I will speak about this mostly from a buprenorphine program perspective, I think that much of what I'm going to talk about today can be applied whether MOUD is part of the treatment plan or not. Okay, so I wanted to start today with just giving a little bit of an overview of the services we provide at St. Luke's Penn Foundation. So as I'm speaking about different things, you have a little bit of a perspective to that. So we are a screening and assessment site, and we also provide both outpatient IOP services. And those services are focused on promoting recovery, building skills, developing support systems for the individuals that we serve, all focused around the treatment goals that they identify for themselves as part of the program. We also offer psychiatry in both of our outpatient and IOP programs, as well as MOUD and MAUD if the client chooses those services. We do also offer an injection clinic here so that individuals can schedule their injections through that clinic rather than scheduling an appointment separate from that. So it provides some efficiencies not only for our provider, but also for the individuals we serve, that they receive their medication check as well as their injection at the same time. We also offer a program called Mobile Engagement Services, which is outreach and intervention service that is offered within the community. So the staff of this program are typically case managers or certified recovery specialists, and they go out into the community, meeting people in their homes or other locations that are comfortable for the client. We also, in that program, work to engage individuals in homeless encampments and other areas where individuals may not seek care, but are open to talking with a member of our staff. We also offer referrals to other recovery supports and services in the community external from our organization. So if somebody requires services that are specialized, in Bucks County, there's a MOMS program through the council. We would make a referral to that program for a woman who is in need of those services. We also work with external and internal programs to focus on social determinants of health. We all know that things like transportation, childcare, and housing can make it difficult for individuals to fully engage in treatment and achieve their recovery goals. So it is really important for our program that we're ensuring that individuals are connected to the services to have those needs met. And then we also offer harm reduction supplies, naloxone, test strips, and wound care kits that are available not only to the individuals we're serving in our programs, but also to the community. And those materials are provided to us by the Bucks County Drug and Alcohol Commission. And then lastly, we offer and try to engage the individuals we serve in community events. We have an annual recovery walk, which this will be the 4th year for that. Iron Pigs games, movie nights, present wrapping, which is an event we hold just before Christmas every year to wrap presents for the individuals in our residential services. And we always encourage alumni and current clients in our community-based or outpatient services to participate. We also offer a weekly support group and then bi-monthly events such as speakers and other events to keep people engaged with our agency, but outside of the treatment setting. And it also exposes the individuals to other people seeking recovery and working toward their treatment goals as well. So just sort of our general philosophy in all of our programs here at St. Luke's Penn Foundation is that we do believe buprenorphine is a valuable tool that has been shown to decrease the risk of overdose deaths and help individuals meet their recovery goals. We also offer buprenorphine as part of a comprehensive treatment plan that includes counseling, recovery supports, and other resources. The other piece is that I wanted to mention here, since we will be talking about positive drug screens later in the presentation, but the American Society of Addiction Medicine does note that the recurrence of substance use is a common symptom of addiction and should be addressed as part of the treatment plan. And that is what we hope to do by utilizing our intervention approach when individuals are struggling in services. And to improve treatment outcomes, ASAM also recommends strategies to engage and retain patients in care, even those who are not abstinent. And so, many of us who worked in this field for a long time know that at one time, most programs were abstinence-based. Our program was abstinence-based at one time as well. And although, we do believe that people have better success achieving their goals if they're abstinent, abstinence is not the only piece of it. And certainly people can make progress even if there is a recurrence of use during their care. We also know that SUD, substance use disorders, have a debilitating impact on psychosocial functioning, which also indicates the need for holistic care that combines medications, counseling, and recovery supports. So our goal is to really have those pieces of the treatment plan be not competitive, but more complement one another. So, like I mentioned previously, while we would love to see abstinence because we believe individuals are more successful in meeting their goals that way, we also do work with individuals as they reduce their use. We have seen many individuals in services, as I'm sure many of you have, who choose buprenorphine for their opioid use disorder, but they may still be using methamphetamines or alcohol. And it may take time for individuals to understand how those other substances continue to impact their goals. And so we work with individuals through that throughout the course of their treatment with us. So utilizing that integrated approach is really important in providing education as well as strategies and skills to focus on reducing the frequency of their use while they work toward treatment goals. And one of the big pieces of this is stages of change. For individuals to understand that change is not linear. We don't one day decide that we want recovery and the next day, we're where we expect to be. And so it's important that we educate the clients that we're serving on the stages of change to have them understand that ambivalence is normal. as is a fluctuation in the level of motivation from day to day, hour to hour sometimes. And normalizing those things for the individual can really help with frustration tolerance, with the shame sometimes that individuals often experience when they do have a recurrence of use. And to have them understand that recurrence of use can occur at any stage of change, whether it's early recovery or they've been in recovery for 10 years. It's always a possibility, and that's why it's essential that individuals are working toward their treatment goals and their recovery goals on a consistent basis. And understanding these stages can help individuals in identifying what their treatment goals are and having those goals change throughout their recovery journey. So how do we do all of this? These are the key factors that we utilize in our program to work with individuals toward meeting their treatment goals. So shared decision making. This is really important in terms of deciding what treatment an individual requires, as well as identifying goals for their treatment plan. So while individuals may turn to us as the professionals sometimes on what do we think they should be working on in treatment, it really is important for individuals to understand that these are their goals, they're not our goals, and that we are here to really guide them throughout that process, um, as they identify what's important to them. So in the current moment, what might be important to someone is to find housing or to get a job. It may not be to stop using. Um, However, those, to decrease or to stop use may be something that would be really helpful in them being able to find a job and working toward finding housing. And even throughout our intervention approach, one of the things we want to work with the individuals on is, identifying what are the things or interventions that you need to put in place to achieve your goals if you're currently struggling. We want clients to be invested in their goals, and we want them to understand that achieving goals requires work, and we want them to be an active participant in their own journey. Evidence-based practices are another big piece of our program. Um, just to mention a few that we utilize in our services is motivational interviewing, CBT, DBT skills, seeking safety, TREM, medications as well, and harm reduction. And I'll talk a little bit more about how we utilize some of the evidence-based practices when we get into the intervention piece. Recovery-focused activities, incorporating different activities that support long-term recovery and engagement in the recovery community. Treatment is a piece of that, but also skill development, case management, some of those recovery activities I mentioned previously that we offer on our campus here. But there's also a lot of community activities that promote recovery that we also make available to the individuals that we serve. If we have flyers from other events, we will hang them up in the building so that individuals are aware that they are occurring. Because as we know, one of the big pieces that could be a barrier for people is isolation, boredom, and also not having the supports that they need to achieve their goals. And then also flexibility in treatment delivery. Offering treatment at varying hours of the day, evening, afternoon, different programming to accommodate the individual's responsibilities outside of treatment. We all know that if someone is, living in a recovery house, they have to work to be able to afford their rent. And how do they fit in treatment around that? So we want to make sure that we're being flexible in terms of when we're offering services to meet the needs of those individuals that we're serving. Okay. So now just to talk about some of the situations that we identify as necessitating an intervention. So if someone is participating in our program, and they're struggling to meet their treatment goals. Some of the things that could contribute to that are recurrence of use. And of course, when we're looking at that, we're looking at the severity and the pattern of use. Was it a one-time event where an individual experienced a trigger and ended up using? Or is it a situation where someone is using, every day or every other day, and it's starting to really impact any progress that they've made? Not attending their scheduled sessions. So here we're really mostly looking at no call, no show situations. And is this happening frequently? Are they in an IOP and they're not attending any of the group sessions and only showing up for individual sessions? And then also not providing urine samples. Um, to some extent, we monitor progress through this, but another piece of that is it is also a piece of our regulatory requirements. We also want to monitor the presence of buprenorphine if the individual is on buprenorphine to ensure that there's no diversion happening. Attending sessions under the influence or using substances on our program property is another scenario that might necessitate an intervention. Controlled substances being prescribed by providers outside of our facility. Um, One of the things that our providers, our physicians and nurse practitioners want to have open communication with any primary care physician, psychiatrist, or other provider that the patient may be seeing, and they may be prescribed a benzodiazepine or a stimulant medication. And so we want the client to disclose that to us so that we are aware that they're on this medication while also being on buprenorphine, and also for the opportunity for our provider to communicate with the other provider. We have run into situations where we have had clients who are on buprenorphine who are also maybe receiving a stimulant and a benzo from a primary care physician. And how does that impact the individual's treatment goals? Sometimes is that necessary? It may be, but we want provider to provider communication to be able to have those discussions and determine what is appropriate. Um, and then not participating in treatment planning, as well as signing the required documents for the treatment episode. Um, Again, some of this is holding the individual accountable. For like treatment plans, for example, while DDAP does not require a signature on a treatment plan update or review, Medicaid does. And so we have to ensure that those pieces of our requirements are being met as well. So we also those are also opportunities to update the treatment plan. So if the individual is not participating in that process, that really is a challenge for, obviously progress in their treatment going forward. Some of the things that we consider when we're looking at interventions, is the client engaged in services and are they communicating regularly with their therapist? Or when we're outreaching to them to schedule appointments and to check in with them, are they not responding to us at all? And that's a real challenge because, at times we do see sometimes that individuals only show up for their med appointment. And so we want to take a look at that. What is the barrier for them coming to their treatment sessions with their counselor or their group therapy sessions? Um, is there a transportation barrier? Is there some other barrier that's preventing that? There might be, maybe they have a sick child at home, or, maybe they're sick themselves. But when we see a pattern of those sort of things, that's where we really want to intervene and kind of really find out what's going on here. And the other piece is the client working toward their treatment goals? Are they doing meaningful work in between sessions? Are they employing the skills that we're teaching them in their therapy sessions or in their group sessions? So those are sort of all of the things that we're kind of looking at when we're considering if an intervention is appropriate. Um, So when we have an individual who does test positive on a urine drug screen, how do we manage that? So that's a conversation that we want to have directly with the individual. When they come in for their next session, we talk with them about, the test result itself. We want to foster open communication with the individual. We don't want to be judgmental. We don't want to be punitive in our approach. We want to approach it with empathy, and with concern. We also want to really focus on how it impacts their treatment goals. Reviewing what their goals are, having them be able to talk about how they feel this impacts their treatment goals, and their ability to move forward. Again, if someone does have a recurrence of use, we're looking to sort of interrupt that process so that it doesn't become ongoing use where it really does impact any progress that the individual has made, during their treatment. Oftentimes individuals will be honest and will be open with it, sometimes even before we do a urine drug screen. And so again, we do use this as a sort of a monitoring tool, but we also want to use it as a therapeutic tool and show how it impacts treatment planning. Some of the therapeutic interventions that we use when we have conversations about any of the, um, you know, situations that would necessitate an intervention, we're really using a lot of CBT, looking at triggers, cravings, how the individual is responding to triggers. Um, we want to look at, what's been helpful for them in the past. Are they using those skills that have been helpful in the past? How can we reduce some of those impulsive reactions when we're having a bad day or when a family member gets sick or someone passes away? We really want to have an open conversation with the individual, um, surrounding those things, relooking at their relapse prevention plan, um, giving reminders on these are some of the things that have been identified. We also look at, do we need to make an adjustment to the treatment plan, goals based on what is currently happening in this individual's life? We do want to ensure, again, that they're putting in the work, right? Recovery just doesn't come to us. We have to really put in the work day to day, just like any other goals that aren't substance use related. If someone has a goal of buying a car, they have to save money. That also may mean that they work extra hours at their job to continue to save money to be able to get that car. So really putting in that work to make those changes. Even when you're talking about someone who wants to lose weight, they may say, okay, I'm going to stop eating fast food, but 2 months later, their weight hasn't changed at all. Then they need to put different interventions in place. Maybe they need to start exercising. Maybe they need more protein. So really adding additional things into their situation to be able to meet the goals that they need to meet. And then also a part of this process is treatment team collaboration. So our treatment team typically consists of a clinical supervisor, a counselor, and then the physician or nurse practitioner who is seeing that client. So anytime we're considering interventions, we want to make sure that all members of the team, including the client, obviously, are that this information is communicated with them. We want to ensure that, all treatment team members are on the same page, um, for responding to situations when an individual is struggling to meet their treatment plan goals. Um, we also sometimes can have treatment team meetings that include external sources like children and youth workers or probation officers, could be a family member even, to address some of these challenges. So on this slide, we're just showing some of the examples of the interventions that um, we often put in place for the different levels. And so we separate our program, our approach into 3 levels. Level 1 being, an initial concern of some sort related to some of those situations that we spoke of previously. So if someone has a couple of positive drug screens in 1 month, or there's a pattern of missing sessions as an initial situation, we might employ some of these what we call level 1 interventions. So um, we could employ multiple interventions or just one intervention. It really depends upon the individual. And so, again, we're considering all the things that I mentioned previously. Is the individual engaged? Are they working toward the goals? So, more frequent drug screens, a referral to case management or recovery supports, or encouraging someone to engage in those services. Um, Engaging in some kind of recovery supports within the community, such as 12-step meetings, Proact Recovery Center that we have in the area where we operate, smart recovery, church groups, alumni groups, things like that. Completing a written recovery plan if they don't already have one. Um, and then also, during the level 1 intervention, we typically would not necessarily look at changes in level of care, right? So this is sort of, you can look at it like sort of early intervention, right? We're identifying that something might be going on with this individual that is impacting their progress in treatment. Um, I also want to mention that, this is a flexible approach. We really do need to look at the individual situation of each client that we're working with and what their needs are. Um, when someone joins our outpatient program and they are on buprenorphine, all of this information is presented to them at the time they begin the program. So they are aware that we have this intervention system to really interrupt any kind of, process that may be heading down a downward spiral. Um, and and really some of these this way of sort of teaching accountability, and having them choose, which interventions, do you think would be helpful for you? And again, this is just a sample of them. A client could perhaps come up with their own intervention that might help them work toward their treatment goals. Um, and so, lower level interventions can be employed at any point in this approach. And I also do want to mention that after 30 days of positive engagement in the program, um, they are no longer on an intervention phase. So if someone got to a level 1 and they go 30 days and things are going really well, they're making really great progress, at that point, they're no longer considered to be part of that level approach. Um, so if 3 months down the line, something occurs again, they wouldn't automatically go to a level 2 because they're not currently on a level 1. Um, and so, level 2 interventions. So these are typically employed when we see individuals who are already on a level 1 and sort of continuing to struggle in treatment. They're not meeting their treatment goals, and they may continue use. It may be an attendance issue. They may not be, they may have legal involvement, and they're not meeting their legal requirements that are connected to their treatment here. And so during the level 2 interventions, we would really look to have a team meeting with all of the players at that point. We may recommend increased treatment hours. So if someone's an outpatient, that might not necessarily mean they go to IOP, but it might mean that they attend 6 hours of outpatient instead of 2. So we would really be looking at that, again, in collaboration with the client. Um, More frequent drug screens, a change in the frequency of the prescriptions that they're receiving for their medications. Sometimes the provider might choose to provide 2 weeks instead of 4 weeks of prescriptions, and then at that 2-week mark, conduct a drug screen. Again, that would be based on whether or not the individual has had a recurrence of use. We might then require attendance at 12-step meetings, whereas in a level 1 intervention, it's encouraged, it's recommended, but not required. So we may start requiring those things, or require that they participate or get a CRS or a mobile engagement worker to kind of work with them throughout the program. Again, increasing the intensity of the interventions um, with the treatment goals in mind. So, and then also may be placed on a written contract. And contract's probably not a good word, but a therapeutic agreement that an individual is agreeing to do these things that they've identified that will help them to achieve their goals. Sometimes our clients are very concrete, and having that written relapse prevention plan or that written agreement can really be helpful to them. It's something they could carry with them and refer back to if they need to. Um, we often see that be successful with some of our clients who continue to struggle. Um, we also want to ensure throughout this process that they're utilizing their coping skills. Again, if they're attending group sessions or individual sessions, really checking in at each session on what skills have you used since the last time we met. Were they helpful? Were they not? Identifying new skills if necessary. And again, looking at what's been successful for them in the past. Oftentimes I think people don't think to look back at, well, when I did really well during this 2-month period, these are the things that were really helpful to me. And then someone could start off in a level 2 intervention if we had concerns that were more significant. If someone is, perhaps comes to group under the influence, at that point we may go right to a level 2 intervention and skip over the level 1. So it would have to be a situation that's a little bit more significant that we would start there. And then the level 3 interventions. So again, this is something that would come over time for most individuals, right? They continue to struggle after some of the level 1 and level 2 interventions. So at this point, we would be looking at, does this client need um, an updated assessment to really look at a higher level of care, whether that be, IOP, whether it be detox or residential services. But we would really be looking to move that individual to a higher level of care. Um, for individuals who may be diverting their medications, or we have other additional concerns around medication, we may look to transfer them to another treatment provider. Um, our providers become very concerned when diversion comes into play. And so that's one of the challenges that I feel like no matter how much we work with an individual, the providers really become uncomfortable with continuing to prescribe in those situations. So we would look to make a warm handoff to another provider, or we may issue instructions to taper off the medication if that is what the client chooses. Um, Certainly, we run into challenges with this, especially when we have situations of a client who might be county funded, where they really can't go to another treatment provider because the medication only gets paid for at a provider such as us. And if there isn't another provider in a relatively close distance, that could be a real challenge. And so, in those situations, we really kind of work together on how can we best support this individual with what their current situation is. And we have had to do that in some situations. Um, and again, our goal here is to really help individuals and guide them to meeting their treatment goals. And so by having sort of a structured approach to, increasing that accountability for the individual, knowing what their strengths are, knowing what things are helpful to them as they move forward, that's really our goal here. It's not meant to be punitive. It's meant to really just increase the intensity of what we're doing to get to that, successful piece where someone can identify themselves as meeting their treatment goals. Um, the- Sorry, my mouth is dry. And then now we have a case discussion to kind of go through and kind of implement some of what I just talked about. Gloria, did you want to read this or do you want me to read it?
Whenever you're comfortable with, Amy, if you want to read it, feel free, and then we'll open it up. I have a couple questions after.
Oh, good. Okay. So, and this is a hypothetical case. This is not a real case, just to mention that. So, James is a 32-year-old male enrolled in ASAM Level 1 outpatient SUD program, while also enrolled at the same agency's buprenorphine program. He has a history of opioid use disorder and has been engaged in treatment for 4 months. He attends individual counseling and group therapy each 1 time per week. He is prescribed buprenorphine, but has had 2 positive drug screens for fentanyl and cocaine over the past 2 months. At his last session, James disclosed that he has been struggling with cravings and stress related to housing. His counselor noted that he has been actively participating in sessions, but has missed 2 groups in the last month. His most recent drug screen was positive for fentanyl and cocaine. He has been with his partner for 2 years, and they are a positive support for his recovery, but James' return to use has been a source of strain in their relationship. James accepted a referral to the program's recovery support program and met with a CRS once. According to the intervention system, James may be placed on a higher level intervention due to continued substance use.
Thank you, Amy. Thank you so
Sure.
much for that presentation. And after reading the case discussion, how would your intervention system address James's continued substance use while maintaining a therapeutic and strength-based approach?
So I think considering James is identifying that he's struggling with cravings and stress related to his housing situation, as well as mentioning the strain in his relationship with his partner, I think those are some things that we would want to really focus on in his individual therapy sessions. Really looking at, what is the source of that strain? Is there a connection between the recurrence of use and the relationship? What are some of those situations where um, it is triggering a craving, and really having him look at um, keeping a log perhaps of the cravings and what's happening, what are his emotions at the time, really utilizing some of those strategies to kind of keep track and really gain some insight into what's contributing to the cravings. In terms of the housing, really looking at, you know, what is the situation that is causing that stress? Is their lease running out? Is the strain on the relationship making him nervous about not having a place to live in the future if there's continued strain? So really looking at what is the source of that stress and what are the options for addressing those housing needs. Um, whether we connect that individual to a case manager to assist with finding other housing options, or addressing the concerns that might be leading to the stressful situation surrounding perhaps a session with the partner to walk through some of these things. Sometimes we know in relationships, whether it's a family member or a partner or just a friend, sometimes there's not that understanding about the recurrence piece, being part of the process. Um, and maybe having James identify how his partner can be more supportive to him or how his partner can help him when he's experiencing cravings. And, do they have open communication surrounding that currently, or is that something we need to help him build? I think in terms of looking at the level system, um, I think to me, this is sort of a level 1 intervention. We already mentioned that he was referred to the CRS, so we would want to encourage, maybe more frequent engagement and contact with the certified recovery specialist, and hopefully have that person kind of work with James related to his cravings as well.
Amy, I'm going to ask one more question and then
Sure.
we'll open it up for any participant dialogue or questions. What role does client engagement play in determining next steps, like reinforcing positive behaviors rather than solely focusing on the positive screens?
Absolutely. So I think, and that's where, during individual sessions, we do have to acknowledge, you know, if someone is, well, in this case, it would be the drug screens, really enforcing the negative drug screens, what helped you to not use since our last session. I noticed your drug screen was positive. That's really great. Let's talk about what skills you utilized or what helped you to not use during the past week or 2 weeks, whatever it might be. Um, I think also when you have an attendance situation, again, acknowledging their attendance, um, recognizing that they've come, thanking them for coming, um, I think is a big piece of it. And we definitely want to engage them in this entire process. If James hadn't already accepted a referral to a CRS, encouraging that, asking if they're willing to do that, if that's something they'd be interested in. We do want to engage them to make their own decisions about their care, and really helping them to recognize when they need to sort of increase what they're doing or increase their engagement in some other type of support, um, to really help move them toward achieving those recovery goals. And I think it's also really important that, when we have the goals and the action steps on the treatment plan, to really, encourage someone and empower them to really work through those and acknowledging when they do, right? So when we are reviewing their treatment plan with them, you know, saying, this is really great. You had on your treatment plan that you wanted to get a sponsor and you did that, and so really acknowledging when they are achieving some of the steps that are working toward the goal, because we know the goal is the overarching, the steps to get there. It's important to recognize those, not just the goal.
Thank you. Thank you.
Yeah.
We have a couple minutes. Does anyone have any questions for Amy or want to share any of your own strategies for handling interventions? We have a few minutes, not much time, but I do see a question from Tamar. Would you consider a higher dose of buprenorphine if he's reporting continued cravings?
Yes, absolutely. And that would be the piece where we would discuss with the provider, as part of the treatment team discussion, on where is this person at in terms of their dose. We also do, and that, thank you for bringing that up, because the other thing we also consider too is when someone first starts in our program, if they're just being inducted onto buprenorphine, we recognize that they are not at a therapeutic dose at that point. Um, and so, you know, we really want to have them understand that as well. And so we take that into consideration as well. If someone is just starting off on buprenorphine, we really would not, um, initiate the intervention approach during that, tapering up to the therapeutic dose.
Roseanne asked if you could talk a little more about harm reduction interventions, if possible.
Sure. So, largely, what we utilize in terms of harm reduction. Certainly during sessions, if someone is really struggling, just say, I know this is more about buprenorphine, but say they're struggling to stop drinking, that they're on buprenorphine, but they're still drinking. And they really are ambivalent about stopping their alcohol use. Maybe they drink on the weekends. And so, from a therapeutic perspective, we would talk with that individual again about, um, how that's impacting their overall treatment goals. And we may also talk with them about, instead of, drinking Friday, Saturday, and Sunday, maybe on Saturday you have one drink or two drinks, right? To really decrease the amount of alcohol that they're drinking. Because, as we know, people tend to feel better if they're not drinking, right? I mean, even individuals who do not have an alcohol use disorder, who, have a couple glasses of wine, oftentimes will say that if they just stop drinking wine, they feel so much better. Um, Physically, emotionally. So, we, by utilizing sort of a cut down approach, that will hopefully help an individual recognize that maybe they're more productive on the weekends if they're not spending, each morning hungover. They may be more engaged with their family or their friends or in other positive activities that they like to get involved in. Um, so I think that's one way that we incorporate harm reduction. We also utilize fentanyl and xylazine test strips. So if we do have someone who is using meth or another substance, we would encourage use of those, items to decrease risk, right, of any kind of overdose that they wouldn't be expecting by using methamphetamine or cocaine. Um, and then, of course, we also utilize or promote naloxone. So we would want to ensure that, if someone does continue to use opioids, that there's naloxone in their home, that their family members know how to use it. Providing overdose education is another big piece of it. And I think also, we're starting to see in some of the data that there's a decrease in xylazine in the opioid drug supply, but an increase in medetomidine. So we want to ensure that we're educating the individuals we serve on the new adulterants that are showing up into the drug supply, and what the impact of that is, if they do overdose, or does it put them at an increased risk of overdose. So we know that the drug supply is always changing, and it's important that we're really educating the individuals we serve about that, to prevent, unexpected overdose, which we saw so much, especially when, fentanyl, first came on the scene. We saw a lot of, increase in overdoses. And so it's really important from a harm reduction perspective to provide that education with the information that we have. Of course, it ends up in the drug supply before we even know about it. But, as soon as we have that information, we certainly want to share that with the individuals.
Thank you. Any more questions, or would anyone like to take the floor for a minute or two to share anything that you would like to with the other participants? This was great information. It's meant to be a sharing of information, so please don't hesitate to raise your hand, or if we see your hand, we can unmute you. I don't see any.
Is anyone else using any kind of approach like this, or not like this, really? When working with individuals, who are experiencing a recurrence of use, or, attendance, positive drug screens, those tend to be the things that we see that impact um, progress and the ability for individuals to meet their treatment plan goals. And so, if anyone does have that sort of approach, it would be nice to hear about it. Certainly there's many opportunities out there. and oftentimes not a lot of research in managing these things on the treatment side. So.
Anyone want to take a risk and raise your hand? Yeah, we have a couple comments also in the chat thanking you, Amy. This was a great presentation. I'm not going to hold anyone up any further. If there is nothing else, I want to thank you very much for your time this morning. And Amy, thank you for this presentation. It was very informative, and just sharing your experience as a provider and some strategies with dealing with behaviors that are not easy. So it looks like we have some really good feedback in the chat.
Gloria, I'll mention one more thing if I can.
Of course.
So one of the things also that we are just recently putting in place is with the some of the changes to the regulations, no longer requiring the 2.5 hours of treatment per month if the counselor does not feel that the treatment is warranted at this point. So we have created a similar approach to this for individuals that would be sort of on a med-only treatment plan. So typically this would be individuals who are in longer term recovery and are still receiving buprenorphine, from our program. And so, sorry, I got distracted. That's why I don't keep the comments up, because the chat up, because they pop up and then I read it. And so that's typically who we're seeing in this program, right? Is individuals in long-term recovery. But we have, utilized this for other individuals. For example, we have an older gentleman who's been in services at St. Luke's Penn Foundation for a very long time, and really had some medical issues that really prevented him from coming to counseling, on a regular basis or even at all. And he really doesn't have the technology to do virtual sessions. And so he's involved in some other services in the community, as well as at St. Luke's Penn Foundation, to address more of his physical health and mental health needs. And so, we continue to work with him from the buprenorphine perspective, but know that he's in care with providers and case managers from other programs that are really meeting his immediate needs, right? And so he's still in our program. We're able to support the buprenorphine piece, but he's getting the other services in other programs here. And so I think that change of regulation really did make a big difference, in being able to treat people who we know are also receiving services. It's not like this individual is just out there taking buprenorphine and no one's monitoring or doing anything, to see how he's doing. But knowing that that's the case, that has been really helpful to us. And so we've been able to utilize that from a positive perspective.
Wonderful, wonderful. Thank you. We're just about at time. So again, thank you, Amy. If anybody has specific questions, you can write into our VA ASAM resource account that I showed you at the very beginning of the presentation. Our next call is going to be June 2nd at 10 o'clock, and we will talk about DDAP and OMSAS process for joint licensure. So thank you very much, everybody. Have a great beginning of your week, and we hope to see you next month. Thanks, Amy. Thanks so much.
Thank you.